Hello, I'm Dr. Ayesha Butt. Welcome to my YouTube channel again. February being the Macular Degeneration Month, we wanted to invite Dr. Annan back to our studio to talk about macular degeneration. AMD, or macular degeneration, is the leading cause of blindness in the world in developed countries for ages above 55. We talked about diabetic retinopathy with him last time. We loved the video. Everyone enjoyed the information, and we have him back today. Welcome back, Dr. Annan. How are you?
I'm doing great, thanks. It was fun. Thanks for having me back.
It was great. So, we talked about diabetes last time. I think patients enjoyed it. Even those patients who don't have that loss of vision, learned a lot from it. Let's talk about macular degeneration today. We know that it causes central vision loss. What can you tell us about what macular degeneration is? How does it develop? How can we explain patients what that is? And of course, the types and the treatment options.
So macular degeneration is another disease that's also multifactorial. There's definitely some genetics to it. We don't know all the genes involved, but we know for sure some genes are. Smoking is a big risk factor for macular degeneration. It also was for diabetes. The idea is it causes low-grade inflammation in the body. So really, most of the diseases in your body, the core problem is low-grade inflammation. And in the case of macular degeneration, we don't think there's a relation for sugar levels, but there's some genetics. It's more common in Scandinavians, light-colored irises. Age is a good factor because as you age, the changes happen in the eye and there's deposition of proteins there under the retina. So these are the most common risk factors really. Is we tell patients to stop smoking, exercise, have a healthy lifestyle, eat more greens and vegetables, and just get your eyes examined after 50 at least once. If you have no macular degeneration, maybe every few years. But if you have family history, you have a high chance of getting macular degeneration.
That's a great point. So my brother-in-law came, the older son, and I just started seeing thinning of macula. That's all we saw on OCT. And of course, I didn't know what was happening, so referred him out to retina specialist. What is the earliest, the basic sign of macular degeneration, on OCT as compared to just looking at a photograph and seeing spots on the retina?
Yeah. So the OCT is more sensitive way of looking at the retina. It can make you see sections through the different layers of the retina. It sometimes you can see better than what we can see with our own eyes. So the first thing you see on the OCT is not usually thinning of the retina, it's the beginning of deposits. We call them drusen, which is accumulation of proteinaceous material over time under the retina. And they start increasing in size. And then there's underlying changes in the vasculature under the retina. And then when there's bleeding or leakage from these vessels, then it's called the wet macular degeneration. So if there's no leakage and there's no bleeding, it's still in the dry type, which we tell patients to do lifestyle changes. When it's the wet type, we start doing injections in the eye because the wet type really progresses faster. So if you don't act on it, it can bleed more and scar and limit your vision faster. So the injections are great. It's a great advantage that we have at this point, that they can limit the progression of the disease. The injections themselves are not a cure. That's why you have to get it at least once a month and keep your appointments for follow-up. If you have the dry type, you don't have to come every month, maybe every few months, depending on the severity.
Sure.
And there's atrophy or thinning in your retina, but that has to be examined by the special test like an optical coherence tomography, or also you need an eye exam to make sure there's no bleeding in the eye.
Sure. A couple of years ago, we started doing OCT on all of our patients above 55. And it's just an amazing way of explaining as well. I said, a photograph is a photograph, but when, you take a photograph of a cake, it looks pretty. But OCT is like a slice of cake, so you can see the icing on it. And that's how patients understood. I can't explain and tell you how many patients we diagnosed early on by just doing OCTs on our patients, and we were able to diagnose early. One of the questions I had in my mind for, of course, my husband and my brother-in-law, is there any genetic testing that they can do to maybe identify higher risk of, developing macular degeneration in patients?
Yes. So there's some genetic tests and some genetic kits that came around that can tell you what the risk of you of having macular degeneration, but I don't think it can stratify you. It can give you a risk. So the higher the risk, the more the chances you have it. But it doesn't really tell you if you're going to have a bad visual outcome or not. It just tells you the risk of getting macular degeneration.
Sure. Do you recommend any of those vitamins that are over the counter, Preserve Vision or Tozol or now the Macular Health? What are your thought process on those patients who are moderate to severe macular degeneration?
So these vitamins have been studied on specific categories of patients, not all patients with macular degeneration, because again, it's a spectrum of the disease from tiny accumulation of proteins under the retina to bigger ones, larger sizes, pigmentary changes.
Right.
Then there's damage to the retina with atrophy, and then it comes where there's blood vessels leaking. So these medications were studied in what we call the intermediate dry macular degeneration, where there's some atrophy that starts to begin. And in those patients, it showed that it decreased the progression into severe or advanced macular degeneration, meaning wet macular degeneration, where you have bleeding and leaking, or the advanced stage of the dry, which we call geographic atrophy, which means it's a big area of atrophy around the center of your vision. So these vitamins help decrease the progression of the disease into these advanced stages. So I think depending on your clinical findings, for some patients, we recommend them.
Okay.
Now, for others that don't have these changes and they ask me, can I take these vitamins? I tell them we don't have studies to answer that questions for you. I don't see a harm in doing it, but I can't tell you that's going to help you either.
Right, right. So, the zeaxanthin, mesozeaxanthin, and the lutein, you're saying it's more for like those dry macular degeneration patients who have atrophy, but for wet, you instantly want to start the injections, but there is no study on those patients with the
Correct.
vitamins. Okay.
Correct, because the study was to see if it prevents progression into the wet.
Right.
But when you have wet, I'm not sure if there's any role for these vitamins, to be honest with you, because you're dealing with more serious stuff, like more leakage and bleeding.
And also, we can't prescribe them to patients who are smoking. So, I shy away from those advanced.
Now the added studies were done initially and they recommended a formula for people that don't smoke. But then another formula came out called the ADDEDS 2 formula, which is okay for the people that can't smoke. So now I just recommend the ADDEDS 2 for everybody if they are in the category of patients that benefit from it.
Oh, that's great. Any help with sunglasses? I know patients sometimes talk about macula and prevention. Also, what about blue light?
I really think sunglasses do help. From an experience with a patient, he used to drive like 40 minutes to see me. And when he drives without his sunglasses, when he comes to my clinic, his vision is not as good when he drives with his sunglasses on. And it was that his observation. Because when he sees me, I'm not seeing as good. But examining him, there's no bleeding. The OCT picture is the same. And then following visits, when he comes wearing sunglasses, his vision is good as it was. So I think there's some role there. I don't know if we have a good evidence, but I think wearing sunglasses is a good idea, especially in Texas.
Yeah, that's what I might tell my patients. But there are.
I can't drive without sunglasses. I don't have macular degeneration.
I mean, ever since I moved to Houston, I don't know how. But there's this new, how people come up with new ideas, and a lot of my patients have actually brought this point that the sunlight is natural; it should be good for you. And that's where I'm like, no, we know that it causes cataracts,
causes skin cancer if you
and skin cancer, and with this. What is the role of dark adaptation testing? A lot of my colleagues, I don't do it necessarily in my office, but what is the role of dark adaptation test for macular degeneration patients?
I mean, I've never done it on my patients. I don't really know what the benefit is from doing it with patients with macular degeneration.
Maybe early detection. I have to still kind of read up on that.
Could be, but usually dark adaptation is the peripheral retina. Macular degeneration affects really the center of your vision. So I really don't see a relation.
There's a lot of,
for macular degeneration?
Testing for macular degeneration. One of them is actually testing the pigment in your skin. And then the Macular Health, which is one of the vitamins that I recommend to my macular degeneration patients, they actually test your skin pigmentation, and it should change
when you take
basically when you take vitamins. And it needs to be at a certain level. There's also this vision test for macular degeneration, but long time ago we learned about some in-office genetic testing as well. Of course, I don't do that in my office, but for your patients who are elderly and they have children and grandchildren, they may be interested in getting to know if this is something that they need to worry about.
So we have genetic testing for retinal degeneration in general, not only for macular degeneration. And it's actually an easy test to do. They just spit in the tube and you send it out for testing. So it's very user-friendly, but it detects all genes for retinal degenerations. I think that could include macular degeneration. But we do these testing on people that we think they have some degeneration in the retina, because now there's some clinical trials for specific genes for retinal degeneration to see if they qualify for these trials or not.
Oh, great, yeah. What are some of the treatments available in the US for macular degeneration?
So as we mentioned before, there's two types. There's the dry type and the wet type. At a certain stages in the dry type, we recommend the AREDS2 vitamins. And if you have the wet type where you have bleeding in the retina or leakage on vessels in the retina, then we recommend injections. And we do inject anti-VEGF, antivascular endothelial growth factors molecules. There's few of them in the market, and there's a newer medications that just came out and they are FDA approved that maybe in some patients could last 2 months or 3 months for the injection. But the response really depends on the patient and the chronicity of the disease. So the recent advances for that treatment is the antivascular endothelial growth factors, but they keep evolving with the newer medicines that maybe can last longer in the eye to decrease the burden of injections.
Oh, that's great. That's great. Are there any surgeries that can be done for advanced stages, or the only thing we can do for these patients is injections for now?
So the mainstay of treatment now, or the standard of care, is the injections in the eye. In some cases, if the patients are really resistant and none of these current medications are helping, we have an old laser that was used initially before the injections were introduced, where it's called the cold laser, where it's not really burning the retinal tissue like a hot laser. It's called photodynamic therapy. That's an option for patients that are really resistant to the injections, all the different ones on the market, and it can help in some patients. So we can do that laser around the blood vessels that are growing, try to shrink them with that laser after we inject a dye in the vein, and the lasers like kind of stimulate that dye to clot these small vessels in the back of the eye. So that's an option. Surgical interventions like doing surgery, cutting and going inside the eye, they were done in the past, but really the outcomes didn't show that that's a great thing to do, especially when you have like scarring and bleeding under the retina. It's hard really to reverse that or fix it.
Right. So, Dr. Annan, a patient comes in, they need cataract surgery, and at the same time, they need macular degeneration treatment as well. How do you deal with such cases? What needs to be done first?
So it's always good to stabilize the retinal disease before you do cataract surgeries. The same thing applies if you have patients with diabetes. Now, for macular degeneration, if they are the dry type, you don't have to do really anything. You just go ahead and do the cataract surgery. If there's a wet type that is bleeding or leakage in the retina, they will need injections. Sometimes it's hard to stabilize this disease for a long time.
Right.
So we can plan to do cataract surgeries in between the injections.
Right. So back to my mother-in-law, the real story that happened in our household, we should have really stabilized her retina before moving forward with the cataract surgery, because that led to.
I think at this day and age, it's really a good idea to do a scan of the retina on every patient before cataract surgeries.
Yeah. A lot of time, my patients, I just tell them we need a clearance from, and even if their retina looks spotless, like we just need a clearance from your PCP if they have a cardiologist, that your endocrinologist, and a retina specialist. So we know. And if they have glaucoma, then I send them for second opinion and just a consult for glaucoma as well, because, why not do cataract surgery along with some cataract glaucoma surgeries as well. So the more physicians or specialists we have involved, the better it is, and the outcome is going to be amazing for the patient. So they understand that.
Or at least they know what to expect. If they have something happening in the retina, we can tell them you can do the cataract surgery. It's going to help you see better. Things are going to be brighter. But you have this change in the center of your vision. It's going to limit your vision. But I think it's still a good idea to do your cataract surgery instead of being surprised after cataract surgery why I can't see as good.
Right.
So it also can set up expectations. And
absolutely, you said the right thing. A lot of times we don't want to overpromise.
Yeah.
We want to underpromise and overdeliver. So just having that conversation with the patient and having that kind of discussion and consultation with a retina specialist kind of makes them prepare for it. That it's not going to be day and night after cataract surgery. And then obviously with the retina or the film of the eye, we have some restrictions there.
Yeah.
Well, thank you so much. This was great. I think it was very informative for our patients. If they have questions, if you guys have more interest in having Dr. Annan back for information on retina disease that can happen in early ages, or retinal detachments and tears and holes, please write to us and we'll accumulate that information and we'll get back to you.
Yep, I'm happy to talk to patients and educate them. Thank you for giving me this opportunity, and I'm happy to come in further times.
Thank you so much. Yes, I think this was very educational for me as well as my audience. I can go on and on talking about it, but this is what you do every day and
Correct.
you're comfortable doing it. My job ends by the time we send our patients to you. We're now moving on because our job is very, screening or primary care and limited to that. So, when patients hear it from retina specialists, it just makes them feel that there is hope, right?
There's always hope.
Yeah. Thank you.
Thank you. Thanks.